Hi, everyone, and welcome to our 51st virtual shadowing session. I'm Miriam, and I'm one of the members of the virtual shadowing working group. Today's session is going to be over family medicine and medical school admissions with Dr. Felix Morales. If you guys have any questions about our program, feel free to reach out to us at virtualshadowing@gmail.com or on Instagram @virtualshadowing. Also, these sessions are recorded and will be posted on our YouTube channel, Pre-Health Virtual Shadowing. Next slide. Before we begin, I wanted to give a shout out to the team that makes the magic happen, our virtual shadowing working group. We have Reagan, Rachel, Anirudh, Shayan, me, Miriam, Rohit, Taylor, Elena, Kiana, and Ali, as well as our physicians, Dr. Fowler, Dr. Marchetti, Dr. Salazar, and Dr. Rena. Next slide. Here's a look at our upcoming sessions. All these sessions will be on Zoom and YouTube Live at 7 p.m. Central Standard Time. This Thursday at 7 p.m. Central Standard Time, we're going to be having a bonus session with some medical students from UT Southwestern Medical School. This will be a Q&A panel, but will not count towards credit for shadowing hours and will not have an associated quiz or certificate with it. However, it will still be posted on our YouTube channel. Links to the Zoom session should be in your emails. Along with that, we also have sent out a questionnaire where you can send us questions that you have for the medical students. Next Tuesday, we're going to have a hospitalist join us and talk about her experiences in hospitalist medicine. And on the 25th, we're going to have a nurse practitioner come on and talk about her experiences in family medicine. Also, you can check out our Instagram page @virtual shadowing, where we post tentative monthly schedules of topics that we have lined up. Next slide. If you have any questions that you would like for us to ask Dr. Morales, be sure to put them in the chat as we go along. The working group will be monitoring the chat throughout and collecting all of the questions so that we can ask them during our 2 Q&As. The first Q&A will be during the middle of the presentation and the second will be at the end. Please note that we'll probably save any questions about admissions for the second Q&A at the end of the presentation after Dr. Morales has had a chance to talk about it. Also, quiz information will be given at the end of the last Q&A panel. Now I'm going to hand it off to Dr. Fowler to give us some updates on virtual shadowing.
Welcome, everyone, and good evening from all over the world. It's so good to have you here for our 51st talk, and we're delighted to have Dr. Morales with us this evening, and I hope you all are as excited about having his talk about admissions process and family medicine from out there in the western part of Texas, where it's kind of hot and dry. So good to have you all. We are now approaching a year of virtual shadowing. And we want to do this if you want us to be here. Our current plan is that we're planning to come back in July, which will take us into our second year. If you want us to keep coming back, if you find this helpful, if you find it useful. We have some new planned talks. Already, William says, keep going. We have some new planned talks. One of them is that we thought we would actually do some practice interviewing. We'd like to hear from you in the chat too, if you think that that would be helpful to you. But regardless, what we want you to know is that this wonderful team, which puts this on every week, has come together, a true labor of love, to make virtual shadowing something that can help you in your future career as a healthcare provider. Marion?
Awesome, thank you. Next slide. Perfect. And now I would like to introduce our awesome speaker, Dr. Morales, who is Deans of Admission and Diversity at Texas Tech Health Science Center School of Medicine and a practicing family medicine physician in Lubbock, Texas. Dr. Morales has been one of my mentors during my first year in medical school. He's one of the most resilient people that I know, and every time I talk to him, I leave feeling inspired and motivated to keep pushing through all the obstacles that are apparent in medicine. I'm very lucky to have him as a mentor, and I'm very excited for him to join us tonight and share his knowledge and experiences with you guys. Without further ado, Dr. Morales, take it away.
Thank you. Thank you for that introduction. I'll pay you later, Miriam. So, thank you so much for allowing me to speak to you all here tonight. I'm going to talk. My talk is twofold. As the presentation was, as people are presenting me, I am a practicing family medicine physician at a full clinic here today. Literally, I have someone covering my OB call as I do this presentation. So when I'm done here, I'll be covering our OB call for our department. But I'm also the Dean of Admissions for the Texas Tech School of Medicine here in Lubbock, Texas. So I'll have some information on the admissions process, how that looks like for our school, and any questions or any advice I can give you guys to be more competitive as you guys are looking at wanting to apply to med school. So I'm going to move on. For my personal journey, I'll talk a little bit about how I got to this point in my career, and where I'm going at. But before, I with any journey, I always say it really started with these two people here. These are my parents. This is their wedding day. Almost to the day. It was May 25th, I believe, in 1966. My parents were married in Mexico. I am a first generation American citizen. I am a child of two immigrants. And I bring that point up partly because, as I try to reach out to various audiences, whether it be this group or other student groups I've had the privilege of speaking to, I want to make sure that it's aware that if you're first gen, if you're a son of immigrants or a daughter of immigrants, that it is possible for you to become a physician. And a lot of it, to be quite honest with you, is the love and compassion that these two people in this photograph showed me. They kind of led the path for me. And I'll talk a little bit about each one of their own personal stories and how that impacted my growing up, but more importantly, how that impacted me in regards to becoming a physician. So moving forward, I want to talk first about my mom's journey. My mom was born in a small town called La Rosita, Coahuila. And it's kind of a little small town on the upper state of Coahuila, right below the border of Texas. She is the oldest of 8 children. And the birth order had a huge impact on her life in regards to what she could accomplish. Now, the people in the top right-hand corner are her parents or my grandparents. And when she was 4 years old, my grandfather immigrated up to the border to a town called Santa Elena, Chihuahua. Now, for those people who are in the audience from Texas, you might recognize that canyon if you ever traveled into the Big Bend National Park region. That canyon is the Santa Elena Canyon. What you see on the left-hand side of the photograph is Mexico. When you see on the right-hand side of the photograph is Texas. And the Rio Grande River splits that canyon into two. If you're from Texas and you've never visited Big Bend, I would highly recommend it. It's a beautiful national park. It's kind of deep in the heart of West Texas. If you're not from Texas and you like to visit a national park, believe it or not, we do have mountains in Texas, and there are some there as well. So my mom grew up predominantly just south of the river. Literally, that was her backyard. And so the reason my grandfather moved up to the border was, as I like to jokingly say, it cut down on the commute. He was already coming across as a migrant field worker. He had worked construction jobs. He had done those types of things. He had bought himself a little small piece of land just in the Santa Elena region. And how this impacted my mom predominantly was the fact that, for many of y'all who know, in Mexico, you have limited resources for education. And since she was the oldest, she can only go up to the 4th grade. And you have to literally pay to continue on with your education in Mexico. And so when she got to the 4th grade, she repeated the 4th grade 3 times. Not because of any sort of intellectual disability, because she loved education. She loved learning. And it got to the point where my grandfather said, hey, you have to stop going to school because you got to start taking care of your younger brothers and sisters. And you also have to help me work. And so at the age of 13, 14, she crossed the border with my grandfather, working the fields of West Texas. Now, what made it unique in the sense for her story is the fact that, believe it or not, my grandparents were actually born in Big Bend, and then they were born in the early 1920s. And what made that unique is a sense, in that particular part of the world, in that particular time frame, the border was a kind of this nebulous thing between Mexico and the United States. And so legally, they made themselves American citizens by the virtue of being born on the Texas side of the river. Although all my mom and all her brothers and sisters were born in Mexico, because of my grandparents' legal status, she was able to attain her American citizenship quite easily because of that. And that was of a great benefit for her as she came into the United States a little bit later on in life. Now, I want to shift gears and talk a little bit about my father. My father, this is my grandmother, I should say. My father is the second youngest boy of also of a family of 8 people. Now, he was raised by a very strict, very harsh single parent. My grandmother, raised 6 boys and 2 girls, all by herself. And he was born in a small town called San Pedro, Chihuahua, and that's kind of just north of the capital city of Chihuahua. And Chihuahua is kind of like the big state of Mexico. Now, his circumstances were much different and also much more difficult. In his little small town, which I've looked for maps, and there's not even a map there where I can find San Pedro. There's no school. Literally, there's no schoolhouse. So to the day my dad died, he was illiterate. He didn't know how to read or write. But that never really impacted his ability to do well for himself. Now, as he got a little older, my grandmother asked him to say he was the last of the holdout from his his younger brother and sister were much younger than he was, but to come up to the border. By that point, all his older brothers had moved up north to Santa Elena, where my mom was at. And so my grandmother begged him, hey, let's just move out where your brothers are at. So at the age of about approximately 19, he moved his mother, his 2 younger siblings up to the Santa Elena region, and that's where he met my mom. And that photograph that you saw earlier with my parents, they had met there, fell in love. But at that point in his life, also my father was jumping across the border to work as a migrant field worker. And I always say with my dad, he was kind of the Christopher Columbus of his family. He discovered a lot of portions of the United States. He was a migrant field worker, worked all the West Texas region, the Panhandle, New Mexico, Southern Colorado, and he finally established himself in southwest portion of Kansas. And at that point, he had fallen in love with my mom. He was coming back and forth, visiting my mom from Kansas, and eventually asked for her hand in marriage, and they got married, and he came into the United States. Now, something that I've always disclosed as well, if there's any particular DACA students in the audience, my father was an illegal immigrant, and he was illegal up to the point where he got married, and then he eventually got caught and got deported back to Mexico. And this is the time frame in which he had moved back down to Texas, because by that point my grandfather had moved from my mom's father had moved into the town called Fort Stockton, Texas, because at that point my grandfather recognized that he needed to get some educational resources available for the younger siblings. And when he moved back down to Fort Stockton with my mother, that's when he got caught by immigration, and he got deported in 1968. For a whole year he spent in Mexico. And I always say, by the grace of God and my mom's just stubborn willingness, was able to allow him to become a resident of the United States. Now, all that got fixed. At that point, the only brother who was born at that time was my oldest brother. And so I was fortunate enough when I was born, he had a legal status here in the United States. And so the little small curly-haired fellow you see in that photograph in the bottom, that is me. I'm the youngest of 3 boys. And when my parents moved to Fort Stockton, that's the childhood home that I grew up in. My dad bought the home literally the year I was born. And so my parents had lived there, majority of their lives, or at least my life as well. As you can tell from the city limit sign, it's a small rural town. I always say it's in the true heart of West Texas, in the Chihuahuan Desert. How that impacted me was, twofold. One is, it made me more resilient. It made me dream quite a bit in regards to what I wanted to do in life. But also, the rural physicians in the town were just inspirational. And I really do credit a lot of them in regards to why I became a physician, why I became a family medicine physician particularly. They took care of everything. As we kind of say in our Department of Family Medicine, they took everything from the womb to the tomb. They did surgeries, they did deliveries. Literally, I was born by C-section from a country rural doc in Fort Stockton. And when it came to educational opportunities and services, going back to my mom's story and how much she appreciated education, how much she loved to make sure we received a great education. My mom was very strict. I always say that if I brought home a 92 on a report card, she didn't pat me on the back. She'd ask me what happened to the other 8 points. And so because of that, it just really inspired me to be the best student possible. I'm very proud to say that, my oldest brother was the first to graduate from college, and I was the second to graduate, and I'm the first to go and pursue a professional degree.
Felix, my father did the same thing. I'd come home with an A, and he said, "They're not passing out A pluses."
Yeah. So, I mean, and what it did for me, and I'm pretty sure for you, Dr. Fowler, it just made you work even harder. And so, I ended up graduating high school out of a small class of 155 people. Eventually, I chose to go to Texas Tech as an undergraduate. I graduated with a Bachelor of Science of Chemical Engineering. And as I was deciding to, go on, it was my dream to become a physician. Now, when I got to college, and this is, it was difficult for me to have this conversation with my mom and my dad, because their perception of schooling was like, you got to go into medical school now. And I said, no, there's a process. You have to get an undergraduate degree. You have to apply it to do those things. I literally remember the conversation with my mom and my dad about, hey, I'm going to graduate with KME, but I want to pursue medicine. And my dad's like, why didn't you do that at the beginning? I don't know. You have to get. And I just remember my mom telling me, hey, if it isn't your heart's desire to do this, then go for it. And so I went for it. I graduated. I took a gap year to make myself a better applicant. I applied and got several opportunities for interviews over in medical schools in Texas, but I chose to stay at Texas Tech for medical school. So I got into med school there. I graduated, and then eventually I got into family medicine as a residency program. Partly because, like I said, being from a small town, I felt like I wanted to do everything. And when I got into my third year of medical school, I'd loved the OBGYN. I loved internal medicine. I loved psychiatry. I loved pediatrics. And I thought, okay, it's checking off all the boxes. I'm loving a little bit of everything. And that's what kind of led me to want to become a family medicine physician. I became the chief resident of our program when I was graduating from graduating from our residency program. And that also allowed me to teach medical students. It allowed me to be part of the administrative staff, make some decisions for our residency program. So that kind of planted the seed of me wanting to become an academic physician in one day. So as I got done with residency, I came back to my hometown, Fort Stockton. This is the hospital there. It's about 20 yards just south of I-10. I practiced for the first year and a half out of residency there in Fort Stockton. And I did everything. I did full scope family medicine. I was even taught how to do an appendectomy, which I've never felt comfortable doing. But I did colonoscopies, EGDs, I delivered babies, I learned how to do C-sections. I did everything in that year and a half. For time's sake, I won't talk about, there's some contractual issues, and maybe one day I'll for certain the students at Texas Tech, I'll share my stories of what not to do with the contract when you get done with residency. But I ran into some issues there. But there was a small town up in the Panhandle named Friona, Texas, that was recruiting for a physician. And I always thought, I had every intention to, go work in Fort Stockton for the rest of my years. But Friona came in and they offered me a nice deal, and I could not pass up the opportunity to come back or to come to the Panhandle to practice medicine. So I moved to a town called Friona, Texas, after a year and a half of practicing there in Fort Stockton. It literally is called the cheeseburger capital of the world. And it's a small rural town of about 3,800 people. I was recruited to come and practice medicine. The one thing I had to do when I got to Friona, though, I had to kind of give up practicing OB because the hospital was not equipped to handle OB services. But I did deliver 2 babies in the ER, which was, I see Dr. Fowler smile because I'm sure he's probably done the same. And so I took care of little preemie babies as they were born. I had to go with the ambulance crews. I did everything there as well. I did a little bit more of the ER side of things, obviously not to the scope of what Dr. Fowler's done. and this is also another city limit sign there, but this is the hospital that I worked at. The clinic is the building right behind the sign. I would see anywhere from 25 to 30 patients on a day, every day. I was on call every third night. And then if you were every third day, I should say. So if you were on call, you had to cover the ER. So literally, if you were seeing 30 patients, you would get called to the ER for an NVA. The story I always like to share about my experiences there in Friona, I'll be very honest, I had never reduced a fractured ankle. And I had a young man who was about 10 years old who was in a motor vehicle accident with his mom, and his ankle was pointing like, east. And I took the X-ray and I called up to the Amarillo ER, Northwest Hospital, and I said, I have this young man, and it was an open fracture. I mean, the wound there was a gash, you could see the bone, and I said, I have this open dislocated ankle fracture. I need to ship off. He goes, yeah, definitely bring him up here, but you gotta reduce that fracture. And I said, and I told the ER doc over the phone, I had never reduced an ankle fracture before. And I remember this as clear as day. The ER doc said, just make sure the toes are pointing upwards. And so I got the ankle and I reduced it, put it in the splint, sent it up to Amarillo. And that's one of the stories. And I would come, and then I did that, came back to the clinic, and the patients who were there waiting for me were still waiting for me. Now, the benefit of being children of immigrants is the fact, or Mexican immigrants, is the fact that I'm a Spanish speaker. I'm a native Spanish speaker. Now, I don't speak as well as my mom would like for me to speak at times, but I had a huge Spanish-speaking population of patients, which was a big surprise to me going up to the Panhandle. I lived in the border because I went to medical school for my third and fourth year. I was in El Paso, Texas, but there was a lot of recently immigrated Mexican nationals, a lot of recently immigrated persons from Central America that work in the fields there in the Friona area. There was a lot of dairy farms, a lot of cattle farming. There was a meat packing company that employed a lot of people. And because of that, I became the doc. I became the Spanish-speaking doc. And so my population just grew. And when it came to the finances of things, I really helped our clinic just become a robust clinic in regards to just my ability to be able to communicate with them in Spanish.
Well, Felix, that's so important. Like in the state of Texas, at Parkland, half of my patients speak no English. And most of that is Spanish, though occasionally it's Arabic, Urdu, Mandarin, Chinese, and so forth. Also, the story that wonderful story about reducing that ankle is that's sort of the difference between suburban or even frankly rural medicine and what we do at Parkland, where we are a medical school. And so I've got hungry residents, but also the orthopedists who want to come down and reduce those things. So for the students listening, the 400 students, by the way, who are online listening to you and hanging on your words, Felix, right now, that depending upon where you go, if you offer yourself to a rural community somewhere, you become indispensable to that community, don't you? Wouldn't you say that, Felix?
Yes. I mean, there have been statistics that show how much a physician coming into a rural area just impacts the economy of that area. Because, in my example, although Friona is a town of 3,800 people, the service area was much larger than that. So I had people traveling in from eastern New Mexico to come see me. I had people from literally Amarillo coming down to see me. Small towns like Muleshoe or Hereford, and so I had a huge population. So I know from the time I was there, I know I had a huge impact on that community.
Felix, we had a family medicine doc talk to us about 2/3 of our shadowing experiences back last fall, I think. And he was from a hometown, a smaller town that his father had been the family medicine doc west of Houston. And he left, went to, I believe, A&M, and then went back home, took over the practice, also worked in the ER, would deliver babies, also worked in the ICU, and did palliative care and hospice as well. So you talk about truly cradle to grave. I mean,
yes,
unbelievable.
Yeah. So we always say womb to the tomb. And when I got to Friona, one of my responsibilities too was to take care of the nursing home, because we had a contract with the nursing home there in town. And so every Monday morning, that was my time to go see my patients in the nursing home. So I did everything, and I was really proud of that. And the one thing that when I left residency, because when I was in residency in family medicine, I had more of my focus was my elective time was to do more OB. And it was regrettable that I didn't do a lot of more of the ER. I did my ICU months, but I should have done more, because when I got to that point, I had to do a lot of emergent procedures. I mean, I did tons of intubations. I did chest tube insertions. I dropped central lines in patients. And it was just really a great experience for me in regards to just one, building confidence, but knowing that I was leaving an impact in that community. You know, and as a small town doc, you know, I was the doc, you know, people, that's how I was named. Hey, doc, what are you up to, doc? And I'd walk into a restaurant, and they didn't have to do this, but I would sit down. We got the bill, doc. And no, I can pay. No, we got the bill. And it was just a really great experience for me and my family, because my wife, being a city girl, when she moved to the town, she was like, I don't know about, and then when she got there, she felt the impact herself. Now, you know, and I'll talk a little bit about what happened. I was there, and we were literally going to make Friona our forever home. But during my time as a chief resident, our department chair, or excuse me, my residency program director, who now is the department chair, reached out to me. His name is Dr. Ronald Cook. And he literally typed in a message, and he says, hey, are you ready to come back to the big city? Because I need you to help me. And I could not pass up the opportunity to come back to teach and to be a mentor. And I just figured in my career, I'd have more gray hair in my head before I did that. But I couldn't pass up the opportunity. And there again, we, you know, with my wife's blessing, because at this point of our lives, we had been Texas nomads. And she said, if that's what you want to do, then let's do this.
Hey, Felix, one of the students online said they took your womb to tomb, and they said birth to earth.
But there's another one. It's from womb to the tomb, from the sperm to the worm. There's another one. And so yes, that's how I got into academic medicine. You know, and we still have communications with the community. We have lifelong friends there, but it was just for us. It was just a better move at the time, and like I said, I couldn't pass up the opportunity to come back to teach in my alma mater. Now, I want to shift gears here and talk a little bit about a case study, and this is a case that I like for some participation, if at all possible. And I'm going to read the case to you guys. And so you're working at Parmer Medical Center, Friona, Texas, where I was at. You're a family medicine physician, and a 27-year-old presents to the ER with some symptoms and a complaint of dolor de cabeza y ataques. What additional information would you want to have as you proceed forward, to move forward with this case? And I guess
I would ask to get an interpreter, but you don't.
So for time's sake, I'll kind of talk a little bit about it. So, you know, when I'm talking to students and teaching them about, you know, a proper history, you want to get some more additional information. So, you know, you want to figure out, okay, what is the time? When did this happen? The onset was 4 months ago. It's gradually worsened. The pain described is this kind of dull, light, pressure-like sensation. The spouse states that he's been having increasing seizure-like activity for over the last 3 weeks. He's had some persistent nausea and vomiting. And he recently immigrated from central Mexico, from the state of Chiapas. He worked as a farm prior to immigrating to the United States. Now, in going back to my story of being in Friona, like I said, we saw a lot of patients from Central America, from Southern Mexico, because that's where the jobs were at. They came in to work the dairy farms, the meat packing companies, and the rancher and the cattle ranches in the area. So as we move on with the case study, what is your differential diagnosis? Now, what this means is, what do you think is going on with this patient? You know, off the top of your head, can anyone kind of just tell me, hey, what do you think is happening right now? Why do you think this person's having these headaches, the seizure-like activity?
You know, the difference between a specialist in a field and a generalist, kind of an average doc, is in the rigor of the application of a differential diagnosis. Any old doc can walk in and say, well, I guess you got a migraine. But a true specialist in a field is going to try to work through the character, the location, what makes it better, what makes it worse. Especially, have you had any workup done for it in the past? Many people come in and they've had a CAT scan or an MRI in the past. There's an old phrase about how do you hide $20 from an emergency physician? And the answer is you put it in the past medical history. I'm amazed. And how you hide $20 from a radiologist? You can't. But taking advantage of previous workup that's been done. But I suspect that given the nature of this person's background, this is going to be a very special case.
Yes, it is. So as you start thinking, formulating in your head, and as many of y'all get into medical school, literally during your clinical rotations, an attendant's going to point to you and say, what do you think is happening? And you guys start thinking of all the things, right? So this is kind of a short list of what potentially could be happening to this patient. Epilepsy, could have had an eye diagnosis of epilepsy, a complex migraine, which sometimes can present this way, brain tumor, alcohol abuse, or not amoebic abuse, but more amoebic infection. And so we're going to move forward. So you start asking, what do you need to order? So routinely, you get some basic, labs, a complete blood count, some chemistries. Those come back in a CT scan. Those come back and they show that you do have a slight level elevated, we call WBC count, a white blood cell count. He's slightly anemic. Platelet count's about normal. He does have a little bit we'll call elevated MCV, means his blood's a little bit darker. And then he has increased eosinophils, which is kind of part of the blood differential. But the CT scan comes back and there's a ring enhancing cystic lesion. And so that should hopefully cue you into potentially what's be going on with this patient. So if you look at the CT scan there, right behind his eye, you see that little circular lesion right there. Okay. And so that should hopefully, tell you, okay, this is person probably have some sort of amoebic type of abscess or amoebic type of infection, right? So the answer to the question is what's going on with this patient is his diagnosis is what's called neurocysticercosis, right? It's an infection, and I'll talk a little bit about it. So when we talk about the causes, the main cause is the Taenia solium. It's a tapeworm. Him being a farmer, he probably did work with cattle, with pigs in the farm, contaminated his hands. He probably got some of the contaminant in his fingers, and then the eggs from the tapeworm eventually migrated up to his brain. So anyhow, at this moment, I'm going to stop, and I think this is where we're going to start asking some questions.
Just taking that case for a second, I came from suburbia in Western Georgia near Atlanta, my hometown. And I never even dreamed of neurocysticercosis. And then I came here at age 47, which, by the way, in 2 weeks, I'll have been at Parkland 20 years. So happy anniversary to me. And we see neurocysticercosis very commonly here. And it's a dietary thing. If you don't cook meat thoroughly or eat certain types of meat that may really have these tapeworm cysts really embedded in them, you run that risk. But we have oodles of questions already, Felix. Mariam, you want to take it away?
Yep, we have a lot of questions for you. Okay, so first one, did you add any fellowships during your family medicine residency, like sports medicine or anything? And why did you choose family medicine versus a neuro specialty?
So in regards to fellowships, no, I personally didn't. Now with family medicine, there are various fellowships. There's sports medicine, geriatric medicine, there's OB. There are a few what we call ER medicine type of fellowship programs. You don't necessarily become board certified, but you get just additional training. Hospice and palliative care is another one that's very popular. I personally didn't. I look back and maybe what I should have done is maybe an OB fellowship. I kind of regret maybe not doing that because I had to learn how to do C-sections from. I did a few C-sections in my residency program, but primarily from the docs in Fort Stockton. But so, life happens. And one of the things is my wife was ready for us to move on from residency. And so that's the reason I decided not to do. Now, family medicine and other specialties, like I was mentioning beforehand, when I got to medical school, this is going to sound kind of funny. I'll admit, when I got to med school, I didn't know. I mean, I thought a doctor was a doctor. I thought a doctor did everything, right? And so that was just my experiences growing up. And you heard about pediatricians and ER physicians, but like, what does an internal medicine doctor do? What does a surgeon? I mean, because to me, that's where I feel like that was going to be my home. I mean, I had every intention of doing something in primary care when I got into medical school, and so I never thought about other residency programs. Like I said, when I got into third year medical school and I was, I could do that, I could do that, I could do that. Then at the end of it all, I was like, I want to do a little bit of everything. And that's what kind of ended up making the decision a whole lot easier.
Hey, Felix, what'd you do with the guy with the neurocysticercosis? We're getting a lot of questions popping into chat about that.
There's different treatment plans. It depends on how active the infection is. You can treat it with, I guess, anti-thelamitic type of medication. Right. You can get a neurosurgical consult too if there's any sort of, we call pressure in the brain, hydrocephalus. So there's various ways. It depends on the presentation, depends on how active the infection is.
Another question about the case study was somebody was asking, how do tapeworms travel to the brain? I thought only small and hydrophobic entities can pass through the blood-brain barrier.
Wow, this is very quick. I hate to admit, I don't know the pathophysiology, how, part of it, I think is the amoeba. I think part of it's the eggs themselves travel. How they cross the brain, the blood-brain barrier, I don't have a good answer for. I apologize for that.
They eat their way through.
Okay. Thank you.
They actually physically eat their way through. There's also inflammatory response, Felix, associated with it. Uh-huh. And so thus the glial border barrier is broken down.
Okay.
Somebody was asking, how many years are there in family medicine residency?
It's 3. It's 3 years. 3 years. Uh-huh.
And another person asked, I'm minoring in Spanish, but don't speak super well, and not as well as I read and write. How do Spanish-speaking patients generally feel about providers who make an effort to speak to them in Spanish, even if it's very broken?
Oh, it's tremendous. And every study will tell you, even if you make a minor effort of trying to communicate, it helps with patient care compliance. And then being compliant with treatment plans ultimately saves lives, right? And so even if you're making what I try to do is there's a Teachback method that I teach my residents and students. And part of that is you sit down, you teach the Spanish speaking patient, these are the things you need to do, even if it's broken, even if it's in English, even if you have to write down, journal instructions, it helps tremendously when it comes back to compliance. And ultimately that's going to help, them prevent, progression of diabetes or worsening of hypertension. And so even making a small effort goes a long way.
And, Felix, I didn't speak any Spanish at all before I got here 20 years ago. And, it is so helpful to be humble about it and talk to the interpreters who will help you. They love helping. And, so as long as you can say, diga inhale, exhale, relaje totalmente, donde está duele, and a few things. And I know I sound like an idiot, but the point is that it really helps being able to admit what you don't know and pick up some phrases that at least, let you get through a physical exam.
Yeah. And I didn't mention this in my own personal story, and I apologize for not mentioning this, but, a big part of also why I became a physician is because my dad in particularly had a lot of health issues when he turned 47, he had his first stroke, he had a CVA. And having to be transferred from Fort Stockton to Odessa, which is the next tertiary medical center. I was 13 at the time. And I spent the whole month of August in Odessa Medical Center with my dad and my mom. And I was the interpreter. And I was the person who interpreted for my parents, because my brothers are much older than I am. And because of that, and not in an arrogant way, but I just remember thinking, man, I could do a whole lot better job of explaining things to my parents than what the nurses and physicians at the time were doing, because they're just like literally speaking right over their heads. And for me, it's like that kind of really planted the seed as well for me to become a physician too.
But there's another piece that's occurring right now, and you're talking to an old guy. Yes, I have a flip phone. All the virtual shadowing folks know that. But on the other hand, as you are, Felix, we're surrounded by computers now. And there is absolutely no reason not to run a complex differential diagnosis on everybody now, because the information is there with a smartphone, with a computer. You have every fact in the known universe in front of you and available. And so medicine is really going to change, I think, with the passing years, especially with not artificial, but augmented intelligence. And I'd love to get your thoughts about that.
No, definitely. I think if there's anything that's happened during this course of this pandemic, it's really forced physicians to kind of, get in front of technology. And I don't ever see us going back from not doing any sort of virtual clinic visits. Literally today, I had, the pandemic is, numbers are kind of decreasing locally in Lubbock, but we still have patients who are afraid to come into the clinic. And I did 2 virtual visits here today. And we talk about rural health, rural medicine, telemedicine there's a big push for telemedicine. And at the time when I was in Friona and about to stop working there, they were trying to push a telemedicine portal with the local hospital there. I don't know if that project ever got off the ground, but that's how I see, some form of electronic virtual type of platforms being always in place for us moving forward.
Somebody asked, what is the insurance situation like for most rural patients, and how did your clinic navigate that?
It's a great question. I would tell you this: it was a great payer mix, meaning that there's various forms of funded patients, and a big part of that was the local meat packing company, which basically employed a huge portion of the population there in Friona, provided a great benefits package for them. And then in combination, now Friona in itself, there's a big portion of the population was still below the poverty line. So a lot of those patients also had Medicaid insurance. And then granted, then the other portion of the payer mix was just the Medicare population, the geriatric population. And if the patient, there were instances which I had to learn on the fly. For example, I had one patient one time I admitted with the COPD exacerbation, and I made the mistake of putting him as a full admission, did not have any funding, and was not getting any better. I had to transfer him out, and it was a struggle to get him out of the hospital just because there's no hospital that would accept him as a patient because he didn't have any funding. And it was a good learning lesson for me, just how to kind of navigate that. And I learned, probably could have kept this person in the ER a little bit longer, put him in observation status versus full admission, because that would have made it easier for me to transfer him from our observation status to an ER somewhere locally. But then at the same time in Friona, there was a lot of wealth. I mean, there was a lot of, ranchers with deep pockets, and they often, if there was workers there that didn't have the funding, they themselves would have their, just graciously, out of the kindness of their heart, would pay for their way as well. Now that's unique in Friona, and Fort Stockton was much different. There was the oil industry, and the payer mix wasn't as great. But we had an indigent fund locally in Pecos County, which would help kind of provide some form of funding for at least for a clinic visit, some basic labs. So it is a bit of a struggle in some rural towns, but believe it or not, usually the payer mixes are not that bad.
So Felix, last year I did like 100 interviews, 50 for the admissions committee, and then the other half was broken between the residency and new faculty interviews. And somebody interviewed me back during an interview, and they said, if you could fix any 2 things at Parkland Hospital, Parkland is the busiest level 1 urban trauma center, indigent care center in the nation, busy hospital. I said, I'll tell you, any two things, what would you fix? I said, I'll tell you exactly what it is. And it's that if I have a patient with a problem that needs follow-up, I could give them an appointment and no questions asked, they would be seen. As opposed to, say, somebody's got an awful eye problem and the ophthalmologist comes, sees them on, say, a Monday and says, come to the office on Friday if you can get on the Parkland insurance plan. I have no idea that that patient's going to get follow-up or not. I have no idea. And if I could fix that, and I'm not some bleeding liberal, it's just the fact that with all the money we spend on stuff in this country, isn't it really time that we could render rudimentary care to people? I'm sorry, forgive, but and then the other thing would be the same thing for their prescriptions, is that they could absolutely get their prescription filled.
Yeah, and I totally agree with you. If there's one big thing would be definitely how things are funded. I also feel like there's a lot of excessive waste. Like I take care of patients in the hospital setting, and I feel like there are times where we could get that patient to a rehab center or do something, but there's always these delays. And I'm like, why are we spending all the thousands of dollars for a hospital bed where this person could be already in a rehab center? And there's always pushback from insurance companies on moving patients into so to me that I would say just the excessive waste of how we go about paying things, but more importantly just making sure we have some funding for everyone would be where I would want to fix things for sure.
There's such a paradox and really a split in our country about how funding occurs. For example, I'm sure nobody on this call watches CNN, but I do. For no particular reason, but CNN has 5 minutes of programming followed by 5 minutes of commercials 24/7. And on the first 5 minutes of commercials, it's always the abalabamabs, these new antibodies and IBs for psoriasis, ulcerative colitis, you name it, even for migraine headaches. You know, one of the psoriasis drugs costs $60,000 a year. Who in the world can afford that? I mean, they give up their retirement savings to be able to pay for that. It's such a dichotomy in financing in our country.
Yes. Yeah. I'm one of the few people that watch the CNN still with you too.
Go ahead, Mary.
Perfect. For the sake of time, I'm going to ask 2 more questions and then we'll save the rest for the Q&A at the end. So one person asked, how do you treat or educate patients that may have different cultural understandings of their diagnosis?
Great question. And that's a big issue in regards to our Latino population for sure. You try to kind of navigate the clinic visit or negotiate some sense of a treatment plan, right? Herbal remedies is a big part of our culture. And so you talk to them a little bit about that. You share your own personal experiences if you have some. If not, you try to at least understand where they're coming from, but then also kind of navigate or negotiate the visit where you're going to say, okay, these might work, but these are kind of things that show us evidence that's going to be a little bit better for you. So a lot of it just comes back to understanding and negotiating a good treatment plan for them.
And then last question for now, are family medicine doctors heavily involved in outpatient care or inpatient care or both?
Both. It depends on where you practice, quite honestly. So if you do rural medicine, you're going to do everything: inpatient, outpatient, ER, delivery, and you're going to do everything. If you're in a bigger city, you might do mainly more so inpatient. There has been, I've mentored a few residents through my last 9 years here as a faculty member, and from every year I've been assigned, 1 or 2 residents per class, and I would swear from the 10 that I've mentored throughout this, 5 of those have gone off and done hospital-based medicine, meaning they're hospitalists. And so you can do hospital-based medicine. Depends on the program you go to. I know our program is really heavy in hospital-based medicine too. All right. So do you want me to move on?
I've been in medicine almost a half century, long before hospitalists showed up. And it's been great to actually have hospital-based physicians, largely internal medicine, but actually now with, advanced training in hospitalism itself, around to be able to help you decide who really requires inpatient care versus outpatient care. I do have a standing joke at Parkland about hospitalists. Why do hospitalists make lousy third base coaches? Because they think everybody can go home.
Yeah. No.
All right.
Well, speaking
Huh?
to that, and there's another fellowship program. There are fellowship programs in family medicine for hospital-based medicine, for sure. So I'm going to move.
Well, Felix, the next take it away for the next half. Okay. You're doing great. You've been going 15 minutes. You hanging in there? You need some water or something?
Oh, and I'm good right now. I've been taking some sips of tea, so I'm good. I'm good.
All right. Well, we're here, and you've got 400 people hanging on every word. So great.
So I'm going to shift gears now and talk a little bit more about my current role as the Dean of Admissions, and I'm going to talk a little bit about how do you make yourself competitive in regards to being an applicant. How I got into this role, and like I said, 9 years ago, I was recruited to come to Texas Tech School of Medicine as a faculty member in family medicine. Did primarily that. Lost a lot of patients. Helped with the training of residents. Taught some students, and eventually got into the admissions game by being an interviewer, helping out with some summer programs that they had through the Office of Admissions, and eventually becoming the assistant dean. And when my predecessor, my mentor, Dr. Kim Peck, retired, I became the associate dean, or the dean of admissions. So I have a lot of knowledge in regards to how one can be competitive in regards to being an applicant in the state of Texas. Now, this is our Office of Admissions, and this is where right in front of this brand new building. I'm very proud of where we're at and how we've grown as an office. So when we talk about applying to medical school, you got to have a good understanding who you be applying against. This is kind of the data from this past year. In any given year, you're going to have probably 20%, maybe up to 25% of an applicant pool being from a non-Texas resident. So, the biggest states that we see year in, year out coming into the state of Texas are California, Florida, and believe it or not, Utah. We have a huge population of students applying from those three states. Now, the gender split is always going to be, for the last 4 years, I think, or last 5 years now, more females than males have applied to medical school. So, and that's been the national trend, but also we've seen it here in Texas as well. And in any given year, you're going to have anywhere from 20 to 25% of that pool be from a reapplicant pool. Those applicants who are seasoned, they've gone advising, they've done things that change their application, and they're going to be in that pool as well. Now, when we talk about just the total raw numbers, this past year we shattered records, and normally we would hover 5,500 to maybe 6,000 applications per year. We almost got to 7,500 applications this past year in Texas alone. And that was just through the TMDSCS participating schools. Now, what's going to make things much harder and much more difficult is that Baylor College of Medicine is now going to become a TMDSCS school, meaning that they're going to accept applications only through the TMDSCS application, meaning that 7,500 is probably going to be above 8,000 if I predict correctly this upcoming application cycle. Why is this important? Why is the whole total raw numbers important? Now, when we talk about just the total raw numbers of people who apply, like I said, you got close to about 7,500 applications coming into the TMDSCS portal, right? And if you can tell from that, and that's that big red bar graph, right? If you look at the middle light gray one, from that pool, about half of those, a little bit less than half, are going to get interviews, right? But from those that get interviews, about 2/3 of those that get interviews are going to get into medical school. So what I always tell students is that your goal as an applicant is always just to try to get your very best foot forward, put your best foot forward, I should say, to get an interview. Because if you get yourself an interview, you're getting yourself you're putting yourself in a good position to get into medical school. Now, when we talk about just raw numbers in regards to our metrics, now, these are our Texas Tech. This is what the average applicant looks like coming into our medical school this upcoming August. We have had some shifts upwards, right? Our total overall GPA for the whole pool coming in this August is a 3.8. The BCPM, which is the science GPA, your biologies, chemistries, physics, and math, are now at 3.75. MCAT's a 5.09. But if we look at our out-of-state group coming in, the metrics are always going to be a little bit higher. Or MCAT average there's 514, overall 3.9, and then the BCPM, the science GPA, is going to be 3.8. Now, just
Felix,
keep
what is the
yes,
abbreviation BCPM, please?
biology, chemistry, physics, and math. And so what we do, what the TMDSS actually does for us is they fish out those courses and they calculate that GPA for us. Now, keep those numbers in mind a little bit later on when I talk about our holistic review. Now, when we talk about those who come into medical school, and I'll put this graph here just because I'm sure many of the audience have heard, well, I knew someone who had a 3.0 who got into medical school, or I heard someone had a 3.2 and they got into medical school. Now there are certain instances where that does happen, but as you can tell from this graph, majority of the students who do apply and eventually get into medical school are going to have at least a 3.6 or higher coming into medical school. Now, those students that do have the lower end GPAs traditionally are going to be the ones that have the higher MCATs. And I'll talk a little bit about this on this next graph, because the people will say, well, I heard that someone had a 498, 499 and got in med school. And granted, we have that. We oftentimes have a student or two that do have those metrics and do get in. But traditionally, again, if you have the lower end MCAT scores, you're going to be that person in the higher end GPA graph. You're going to be that person as a 3.9 or a 4.0 GPA. But the majority of students that do come into our medical school are usually going to have a 507 or higher coming into medical school. Now, when we talk about the most common majors, now I'll talk a little bit about our holistic approach. Now, you have to have one of these majors. These are the three most common majors that we often see coming into med school, or who do apply, I should say, those who apply. Biology always being number one, biochemistry being number two, neurosciences being number three, and a very close fourth is psychology. Now, do you have to be one of these specific majors? And the answer to that question is no. We've had anything from English to art history to music education to business to engineering. I'm a chemical engineering major. And so you have people who have various majors that do come into medical school. Now, when we talk about those who apply to our medical school, these are the top 5 schools that we see year in, year out coming into Texas Tech. UT Austin always being number one, partly because of just the mass volume of applications and students that come in from that university. Texas A&M being number 2, UT Dallas being number 3, Baylor being number 4, and University of Houston, believe it or not, beats our own home campus of Texas Tech as that 5th spot. And now, granted, year in, year out, we have probably a big portion of our class are from Texas Tech, but we have a couple of early assurance programs in which they bypass the MCAT score. And so a big portion of that group is going to be those early acceptance students. And believe it or not, does anyone want to venture a guess as who's number 6 on this particular list this year? And I threw out Texas Tech, so it's not Texas Tech. Anyone want to guess? It's BYU, Brigham Young University. Is always going to be in the top 6 or 7 school from those. And as we jokingly talk to other admissions officers across the state, if you're out of state applicant pool is always going to have a big portion of BYU students in it, in Texas in particular. So when we talk about the holistic review and how we go about evaluating an application, now I sit here as a representative of Texas Tech School of Medicine. And I can only talk about how we go about approaching things, right? And I know some schools are going to emphasize other areas more so than what we will. We try at our very best at our school to look beyond the numbers. We want students from varied and diverse experiences coming to medical schools. We know how impactful that's going to be to someone's learning, not only in your first 2 years of medical school, but particularly in your 3rd year when you jump into the clinical rotations, when you start learning about patient care management plans, but you learn from your classmates, from those diverse experiences, right? Because it's our job as an institution to try to create the best possible physician. And we do our very best, I feel like, at Texas Tech to provide just the best medical education possible for our students. So when they graduate, they're going to be a very well-trained physician. Now, when we talk about the holistic review, where does it come from? This is the double AMC, the American Medical Association, or American Association of Medical Colleges Experiences, Attributes, and Metrics model, the EAM model. We use this as kind of our foundation for our holistic review. Historically, it was something that was passed down in the early 1990s. Those life experiences that shape you as a person, your own personal attributes, your own, I always say your own DNA that makes you that person that wants to become a physician. But at the core of any holistic review are going to be numbers, are going to be metrics. And I'll talk a little bit about that next. Because when we talk about our own holistic review, this is how we go about approaching an application when someone applies to Texas Tech. A question that during the discussion prior to this presentation was about healthcare activities and the value of this virtual platform for shadowing. I would say it's very, very valuable nowadays because shadowing, in a sense, had always been a rate limiting step for a lot of students who have been applying to medical school because it's hard to get into a shadowing experience. Now, we never really looked at the number of hours of anyone who shadowing hours. We just want to make sure that you had, when we look at the healthcare experience, we're looking at, do you have an understanding of the medical profession is the big thing that we're looking at. We're not going to count hours. We're not going to look at, did this person do this? Did this person? No. We want to make sure that that student has, or that applicant has some understanding. Because if you come in for an interview to our school, we're not going to quiz you on medical knowledge. No, we want to make sure, do you have an understanding of the time commitment, of the pressure that comes with becoming a physician, but also a student. And we would hope is that through these platforms here, that you're able to at least make connections with students who are already in medical school or physicians who are helping you out in this virtual platform. So you can have some understanding of what it's going to take for you to become a physician. We look at service experiences. I always say, whatever your home campus is at or whatever hometown you're at, try to leave that place a better place than what it was before you got there. We're not going to necessarily count hours on the application. We want to see some continuity of experiences because we always can tell when someone just populates that portion of the application with 100 different things that you did just for 1 hour. Well, we want to see some passion. We want to see how altruistic you're going to be. And particularly for our School of Medicine at Texas Tech, we want you to have a servant's heart. It's very important to us. And you demonstrate that through your service experiences, right? There are applicants, believe it or not, who form their own nonprofit organizations. And so you have to go off and do that. The answer to the question is no. But we want to see some form of passion in regards to that portion of the application. Now, I'm going to skip the research part and come back to you here in a minute. We definitely want leaders coming into medical school. Now, do you have to be a president, a vice president of a student organization? No. But you can be a social chair. You can be a fundraising chair. You can be an active member, right, of a student org. I always say this, I sit here before you as an introvert that's adapted to the extroverted world of medicine because it is very extroverted. And so we want to make sure that you're adaptable. Because a big portion of your grade later on in life is going to be how you communicate, right? And a lot of dismissals from medical school are never any sort of academic issue. It always seems to be some communication issue that the student might have. And so, and then during your clinical rotations, you're going to be judged pretty heavily on your ability to communicate not only with your peers, your team physicians, but more importantly, the patients you're going to be taking care of, right? When we look at letters, yes, sir.
Hey, Felix, we have a committee at Southwestern called the Promotions Committee, which is where kids come who are struggling during medical school. Do you have a similar committee?
We do. Yeah. So Student Professional Promotions Conduct Committee is what it's called, SPPCC.
And what kind of problems do you see? Is it alcohol? Is it they find out that they're in medical school and they really don't enjoy themselves? Is it learning difficulties?
Well, kind of a hodgepodge of different things. We've seen some medical issues that surface up during the course of their first year or second year of medical school. We see sometimes that, students, although in our best judgment, we felt like we're prepared for the rigor of medical school, and then it hits them pretty hard. I always say, going into medical school is like drinking water from an open fire hydrant, and they're just not prepared for that type of pressure. We see the communication issues, and those are the more difficult cases where, for whatever reason, students have been, the conduct of that student hasn't been very professional. We see that often as well in that committee. So it's kind of a different group of reasons why they come to that committee, for sure.
We did a study at Southwestern 3 or 4 years ago looking at students who later as physicians got in trouble with the medical board to see if there was any correlation with their performance as students. And we found two things, interestingly: being late to their assignments, such as rotations, and the other was failure to complete projects on time.
Yeah. Yeah, and that's a big issue, and particularly, and when I talk to third year students, and particularly starting our clerkship or rotation, I say half your problems are solved by just showing up on time, by showing up early, and being an engaged learner. And oftentimes that's a big issue. When coming into family medicine, when they come in, a lot of them don't want to do family, and that's great. What I always tell students is, hey, we want to teach as much family medicine as possible so you have an appreciation of it. We're not here to, convert you into family medicine, but we want you to and some students just don't get that, even that simple basic thing. Or even, they show up and they're so geared on trying to pass that board exam or that shelf exam at the end of the rotation that can I leave early? And I'm like, no, you want to be an engaged learner. And that's where a lot of students get into trouble for sure.
And Felix, one other thing along the way, in this almost a year that we've been doing shadowing, I've tried to be the old grandpa for these kids to some degree and say, look, from what I see, you're going to work so hard to get in school. Please don't do something stupid. Do not drink alcohol and get behind the wheel of a car, because you get a DUI, you're not going to get into professional school. Don't do that if you really are working so hard. And you shouldn't do it anyway. But
I'll get to that. I'll get to that point here in a little bit. And I have a lot to talk about for sure on that part. So when we talk about holistic review, letters of recommendation, very important. I was at a recruiting trip a few years ago, and a student came up to our table and said, our letters aren't, no, they're it's going to make or break you. You saw the volume of applications coming in, right? And it's like splitting hairs. So if you have a warm, lukewarm letter, it's going to affect your ability for sure. So you want to make sure that you have, good letter writers. And I see Rachel in my screen, so I use Rachel as an example. So, a bad letter for Rachel would be, Rachel showed up to my biochemistry class, top 5% student would do well in medical school. A good letter for Rachel is going to be, Rachel showed up to my office hours. She and I had discussions about her dreams and aspirations of becoming a physician. These are the reasons why she's going to be a good student, but more importantly, these are the reasons why she's going to be a great physician. You guys see the difference there. So we want to make sure that you have a good relationship with that person who's going to write you a letter of recommendation. All we request is 3, no more than 4. People have asked me who should write your letters. I always say it's the people who know you the best. Now, granted, people say, should I get a professor type? It wouldn't hurt to get a professor type just to kind of vouch for you in your classroom setting. But the very best letter of recommendation I ever read, it brought me to tears when I read the letter, was from a football coach from a young man who was applying to medical school. And I could see the level of dedication that this young person had in his dream of becoming a physician, right? So you want to make sure you're building those relationships with those letter writers, right? Now, when we talk about research, we don't require research as a component of the application. You can list as much as little as possible. The way I look at research is like icing on a cake or a cherry on top of a sundae. Both of those taste pretty good without the icing or the cherry, but if you have one of those things on top, it's going to make it pop, right? It's going to make it look better. And so if you have some research in your application, it does help you stand out a little bit. Now, the last 2 things, I never like misguiding any group of students on the importance of metrics. It is part of our holistic review. We don't have automatic cutoffs. Sometimes we don't have an automatic GPA cutoff. We don't have an automatic MCAT cutoff. But I'd never like misguiding any students. You saw the average of our institution. We hope to get people close to that average every single year. Now, you can do research in various medical schools in the state or in the country. And my best advice to you in any sort of particular, MCAT particularly, is try to get close to the average. Try to be in the ballpark, right? And what I mean by the ballpark, try to be a couple points away from that average. If you can be a couple points away from the average, then you're in the ballpark. Now, if you're at the average or higher, you're on the playing field, right? In regards to the GPA, same thing. You saw the averages of our institution. If you're close to that average, great. If you're a few decimal points, you're still in the ballpark, right? Now, if you're in the low 3s range, then, it might be a little bit harder for you to get in, but what we look for, and particularly in the science GPA, especially if you're a non-science major, you want to make sure you're doing your best job on that. And I'll talk a little bit about metrics here in a second. So I'm going to move on and talk about common mistakes. So one thing that I noticed that students often do when I go through an advising session, I was like, man, this looks great on paper. And what happened? They submitted their application like a week before the deadline. you'll be amazed in how much just the timing of the application plays a big role in your ability to get an interview, right? I always say the sweet spot to submitting an application is anywhere from the last week of May to the first week of July. If you can get it in with that time period, you're making yourself a great candidate because you're gonna get eyeballs on that application much sooner. Don't use submit as a finish line. In other words, you complete everything, hit submit, you drop the shadowing, you drop the research, you drop, oh, I'm done. No, you want to continue doing those activities just because you never know when an interviewer is going to ask what you're currently doing right now. Don't take the MCAT just to take it. You want to make sure you're fully prepared to take it. And we've read research in our office, anywhere from 200 hours up to 500 hours of study time. If you can prep for that MCAT, it does help you out. I always suggest, examination questions, and you make sure you're taking full-length exams before you, because you want to make sure your brain is wired for that test before you take it, right? Failure to account processing times. The one that gets a lot of people is the letter of recommendation, making sure your letter writers have the ability, then they give them a deadline. Can you please submit it by this date? We offer a secondary application. We require that secondary application before we can review your application. I think there's one school in the state that doesn't require, I want to say it's UTMB if I'm not mistaken. I might be wrong on that. Does not require a secondary application, but all the other schools do. It just adds another added layer for us to how we go about looking at you holistically. We won't look at your application until we have that secondary. So make sure you have those deadlines in your head. What we've done as a School of Medicine here at Texas Tech is we've published our secondary application questions on our website, on our office admissions website. So you can have those handy. So there's no excuse for you to go in, at least type some responses up before you submit your application. You saw our holistic review. You want to make sure you're checking the boxes. You want to make sure you're developing a comprehensive application. If you feel like there's an area of weakness in your application, go back and look at it. If you're a reapplicant, go through an advising session. They'll tell you, hey, these are the things you probably need to be working on, whether it be a metric issue, whether it be some component of healthcare exposure, shadowing, those types of things. They'll be having an honest conversation and try to get a good balanced application. Now, speaking to what Dr. Fowler was saying in regards to the DUI, now there's a thing called Texas House Bill 1508. It got passed a few years ago. I'm going to kind of summarize what it says. Basically, if you have something on your record, it might render you with the impossibility of getting a license in Texas, meaning that there's no going to be a medical school that's going to invest the thousands of dollars in your education. At the end of it all, you can't practice medicine in Texas, right? So if you have a DUI, if you have some sort of, legal issue, it's going to be really hard, to be quite honest with you, right? So I say this with all, sincerity, with all the affection in my heart. Don't be a knucklehead in the audience, right? So, if it is your dream to become a physician, put those blinders on, make sure you're focusing on the dream in hand. When I was an undergrad, that was my dream. Literally, when I was, in my darkest days of taking organic chemistry, I would write down Felix Morales, MD, and would paste that on my wall to remind me that was my goal. On a Friday night when I'm studying in my room or my dorm room and my friends are out partying in the Depot District, that was what I wanted to do. And so you want to make sure you're doing everything you can to avoid any sort of legal trouble that would render you with the inability to apply. Now, have we had students to get in? Yeah, we have, but you want to be accountable. You don't want to be a repeat offender. If you're a repeat offender, forget it. Your chances of getting into medical school is going to be very, very difficult. So you want to make sure that if you have something on your record, that you are accountable, you don't repeat it, you don't do it again. The academic dishonesty issues are also very critical too. And I'll throw that in here as well. You want to be as honest as possible if something happens, but hopefully you on the audience will not have that issue, right? Because if you do, trust me, our committee in our school is very tough when it comes to those issues too.
Hey, Felix,
yes, sir.
Front cover of one of the news articles this week was Dartmouth. You may have seen that. Mm-hmm. Suspended, I think, 17 students for what they said was cheating online.
Yes.
And I don't have an opinion about what actually happened.
Yeah,
but, that made front page news this week.
Yeah. So in granted, with this whole online platform and things like that, it's hard to police, I would imagine, but at the same time, just try to be as honest, because at the end of it all, you get to the medical school, you're going to get a sense of some competition, but try honestly, it's competing with yourself, right? So you're doing yourself a disservice if you're not learning that material, okay? So I'm going to move on. And, what if you did come in and you have some issues in regards to your metrics, right? How do you overcome that? Now, we always jokingly talk about in our office admissions, a strong MCAT score does solve all ills, right? So if you're in that lower end of your GPA and you have, a 5 teens type of MCAT score, then you're doing yourself some good. If you're that non-science major, right? In that BCPM, that science GPA, your biologies, chemistries, physics, and math, you want to make sure that that's going to be very strong, right? Our engineering majors oftentimes have lower end overall GPAs, but when we look at their science component, they're going to be very strong. We talk about upward grade trends. We do look at those, and I'll talk about some examples here in a minute. If you're that student that didn't get in, and you're like, what did that? It was a metric issue. There's tons of post-bac programs in the state of Texas. There's graduate programs, graduate medical school, medical sciences programs. There's one at North Texas. There's one here at Texas Tech Health Sciences Center. There's one in Paul L. Foster in El Paso. There's several programs you can get yourself into to try to make yourself a better applicant. What those programs often do, it does enhance your GPA, but more importantly, it demonstrates that you can handle the rigor of coursework at a graduate level more so than anything else, okay? But when we talk about upward grade trends, this is the ideal student, right? The student that just got to school, went to the library every single day, 3.9, almost 4.0 student, right? That's the student that we like to see applying, right? But more times than not, what we see are students like this. The student that came in from a rural town, came in from Crosbyton, Texas, population of 3,000, right? And didn't have the resources to compete with the kid from Allen, Texas, or from Plano, right? Just because, they didn't have the science curriculum or the science background, right? And they struggled at first, but then they figure it out. They figure out how to study, how to prepare for a test, and they have the upward grade trend. We see those on our transcripts, and we love students like this because we like to capture students who are peaking versus those who have not had this up and down career like this student right here, right? And heaven forbid, my girlfriend broke up with me. My dog ran away from home. Because what this shows us here is a student that wasn't resilient, right? Had that because, and I'm looking at now at Miriam, she can tell you how hard medical school is, right? And how difficult it is. So, and you're going to have some difficult moments. There's going to be homesickness. There's going to be, boyfriend issues. There's going to be things that pop up that you don't expect. But if you're resilient, you're going to be that student that can push through that and not have that up and down career, right? So that's what we want to see, the upward trend or the person who's done really well from beginning. Now, when we talk about the interview, like I talked to you beforehand, it's very important to our process and how we go about evaluating an applicant. There's various types. I'd like to speak a little bit about those various types. There's what's called a blinded interview. Basically, you show up. I know there's one school in Texas, I won't name that school, that does a blinded interview. All they have is a picture and your name. It's an open conversation after that. And then, but we have our Texas Tech is called semi-blinded interviews, meaning that our interviewers have your application minus your transcript, minus your GPA, and minus your MCAT score. Now, we can't do anything to strike every letter recommendation. It's really hard. Sometimes letter writers are really proud about the student. But we do our very best to try to blind our interviewers from our metrics because we want to make sure that student's going to be a good fit for our institution. There are called multiple mini interviews. I liken those to speed dating. You move from one station to the next every 5 minutes. And you have a direct focus question, a lot about the personal attributes of the school. And so you want to make sure you have a good direct answer for that. Now, there are what we call panel interviews where you have 3 or 4 people and they're just kind of peppering you with questions. And always keep in mind the length of the interview. You're probably not going to have an interview longer than 20 to 30 minutes. I think Southwestern and I kind of share the same format style. We have the 2 classic interviews. A lot of schools still have that type of format. But you want to be your very best, very, very best version of yourself, right, during that time frame, right? And be prepared to ask some difficult situational behavioral questions, right? Some questions that are going to throw you into some weird ethical situations. You're going to have to kind of navigate through those as well. So you want to make sure you be prepared for that as too. Okay. So when we talk about the last few things, I'm going to talk about the personal statement. I always say that's the very first place of the application I go to when I review the application. I read through that personal statement, right? It is the only location of the application is going to make you unique. opportunity to directly speak to people like myself who are reading applications. And a poor execution can be very unfavorable. Now, when we talk about the purpose of that application, there's two things. If there's two things to remember, one is don't apply late. But when it comes to writing to the personal statement, you make sure you're clearly stating what has motivated you to become a physician, but more important, how committed you're going to be at achieving that goal. Motivation, dedication / commitment are the two big broad themes you have to convey during that personal statement, right? Because it is your own personal campaign. Now, things not to do, right? Obviously, you want to talk about your motivation. Was there an aha moment in your life that led to that decision point, right? But please, I've read through thousands of these. Don't put, I love science, I want to help people. Everyone does, right? You want to make sure that you're conveying that message without explicitly stating those statements, right? And the other thing I've seen a whole lot of too is just a summarization of their life or their application. No, we can get that from the app. Make it a unique story for us, okay? Now, when we talk about some certain myths, a few years ago, I asked a few people in our office, is there any myths you want like to convey to a group of students? And the very first one that came up is, don't believe everything you read on Student Doctor Network. I know it's kind of a very open form of questions, or excuse me, there's like a blog type of page, right? So don't believe everything you read about it there. There's some valuable information, but it's always wise to maybe reach out to the various office admissions. They'll tell you the truth, right? Because I'm going to Texas Tech, does that mean I'm on the inside track? The answer is no, because we really look at everything holistically. We want to make sure that you're going to be a good fit for our institution. Now, do we love more tech students to apply? Yeah, obviously. I told you earlier, I wish we had more tech students that apply to our medical school. But do you have an inside track? The answer is no, because we look at everything really holistically. My sister received an interview. I didn't get one. That's a mistake, right? No. You got to stand in your own 2 feet. You got to stand in your own merits. And so it's not a mistake. Like I said, we're looking at everything holistically. Although we've had like 2 years where we had twins, and then we're about to have graduate twins this year, which is really awesome. And then we have 2 brothers coming into medical school this next year, which I think is really cool too. My mom and dad is Dr. So-and-so. This is the one I get all the time. Am I going to medical school? And the answer to the question is no. You have to stand on your own 2 feet. You have to make sure that you stand on your own merits before you apply. Okay. And I think that's my last slide. Actually, no, I got a couple more. I'm afraid to call or email because I don't want to be bothered. Now, there's an appropriate way of doing that. You don't want to, where do I go shadow, or, where do I go? No, those are things you have to figure out. You guys are essentially adult learners at this point, right? But reaching out and saying, hey, specific questions about curriculum, those are good questions to answer or to ask, right? So, or I'm doing a search project. How would this, so those are good things to look at it too. Okay. But like you're not going to be bothered, but just don't pepper someone every single day with an email. Okay.
Felix, about the personal statement, I believe very strongly that that it needs to be well written. You see a lot of crappy subject verb agreement and stuff like that. And this is someone who hasn't really taken the time. Maybe they don't speak that well, or they just don't write that well, but it is, after all, an essay.
Yeah.
And so I urge you to have someone critique your essay and make sure that it reads well.
Yes, very much so. Yeah. And just try to get as many eyeballs on it as possible. And, have people who are objective, right? You don't want your mom or your dad reading it thinking, oh, does he love you? No, you want someone who's going to be objective about the message and what you're trying to convey. So if you're, so the last few things is kind of summarizing. If you're that freshman in the audience, start creating that roadmap, start building that roadmap. How do I get from point A to point B and becoming a physician? I always say this during the course of interview day. If you ever interview with us, I always say, my dream and aspiration for everyone is to have the MD behind your last name, right? How do you get that MD? You start creating that roadmap pretty early on. Start building relationships with those people who are going to write letters of recommendation. Stay focused. Your first year should be about grades. Don't get behind on those grades. If you become a sophomore and you look at your GPA, start reevaluating your goals. Am I going to be able to make it to medical school based off my current grades? You guys have all done algebra. You can figure out how many A's you need to make to increase that GPA. If you can, the shadowing, again, it's probably a point time to start it. Granted, under the pandemic, it's harder to do that, but these virtual platforms are great. So try to get involved as much as possible. As things begin to open up, start looking for those opportunities again. If you're that junior, start prepping for that MCAT. I would say if you're in that audience right now, I'm hoping you guys have been studying. I always say the best time to take it would be March, April, so you can have that score ready to go as you apply to medical school. Look at your application, start filling in those deficits. Like I said, the holistic review, look at it as a kind of a balanced scale. Make sure you're filling all those deficits there. If you're that senior and you didn't get in, reevaluate the competitiveness of your application. Be aware of the Casper test. Now, we require the Casper test for an application. We're not using it. I want to tell people we're not using it anyway right now for decision making. We're still collecting data on it. We're going to try to figure it out over the next couple of years. Make sure you're preparing for the interview. Reach out to people who've interviewed beforehand. A lot of universities and colleges have like career centers. You can go to them to make sure you can maybe get an interview or just practice a mock interview. And there again, if you're that person that did not get in, reevaluate your application, consider some post-bac graduate medical school program. Okay. So that's all I have to say here tonight. And I appreciate there again, y'all's attention and y'all's audience. So I'm going to go ahead and stop sharing my screen if that's okay with you guys.
Absolutely.
Okay.
Felix, what's the most number of times, just guessing, that you've seen someone apply? They didn't get in the first time or the second time, that actually finally got accepted. Can you reflect on that?
5 is the most I've seen. 5 times. There's a young man who applied. He became, and as Miriam know, we have a group called the DAs and the Dean's Ambassadors, and they basically are like our student representatives during our interview day. They do a lot for our Office of Admissions. This young man was a Dean's Ambassador, and he had applied 5 times. He actually matched into general surgery not this past year, but the year before last. And so, and a lot of resilience when it came to that applicant.
You said something a while ago that I thought was really important, which was about the fact that as members of admissions for Texas medical schools, among one of the things that we do that we consider very important, we're making doctors for Texas. Mm-hmm. Now, granted, they may certainly move elsewhere, but our job is to make sure that you can pass the school so that you don't drop out, and so that you don't burn out, and then ultimately you become a physician taking care of Texans.
Yeah,
anyway.
and I would say that a big myth and misconception out there is that medical schools try to weed out. No, there's no weeding out. Once you come in through the door of a medical school, it is our job to try to make sure you do the very best when it comes to resources, your education. We do our very best because it is important to us that one day that we hope, and our mission statement at Texas Tech is we want to build physicians for West Texas and beyond. Whether it be West Texas or Texas, we want to make sure you're serving some underserved community, whether it be in an rural inner city area to rural, small town like I did. That's our ultimate goal. So we're going to do everything we can to make sure you have every resource available to you so you can be successful as a medical student.
Just returning spiritually for a moment to that slide you did that you put on timeline. We had a number of students that wrote in saying, good Lord, I wish I had that right when I started school, because now I'm already so behind. Any last closing comments on that slide?
I would say a couple of things is, and I put that up there not to scare anyone. Part of it is just, and wherever you decide, wherever you're at as a pre-med student, some pre-professional offices are really good about helping you with that timeline. Now, if you feel like you're a little bit behind, don't freak out. Like I said, it's kind of a weighted scale. I know, for example, a lot of non-traditional students who have already graduated, they want to come back into their career. They feel a little behind the timeline, but we look at things holistically. So if you're having to work 20 to 40 hours a week to maintain your pay for your tuition or pay for your room and board, we're going to look at those things as well. So if you don't have all those things within the timeline, don't freak out. Just try to do your very best to have a good comprehensive application as you apply.
Different subject. Students contemplating a gap year after college, any advice to them?
It's very common, and we get that question a lot. We have this like listserv amongst people in medical schools, and there's a question about 2 years ago. I got posted that listserv about gap year and how many, what percentage of, when I was just eyeballing things, I think about only about 30% of those students are that traditional type where it's like directly from undergrad into medical school. So vast majority of the students are taking at least one gap year. And so when, I know it's going to sound funny, but when you take a gap year, do something to fill in that gap, right? If you think it's a perceived metric issue, do something to fill in that gap during. If you think it's a research issue, if you think, oh, I need to do better with my literature, do something to fill in that gap during that gap year. But don't be afraid to take a gap year.
Yeah. 10 years ago when I started the committee, we didn't see as many gap years. Now it's more the norm, as you were saying. I think personally, just looking at how folks do a gap year, if it's because you want to take a year off and rest and drink beer and just chill for a year, that will be viewed much less wisely than, say, take a year off, take one post-bac course maybe per semester, learn Spanish. Somebody asked in the chat a moment ago about what about AmeriCorps? Absolutely. But do something, don't become a vegetable for a year, but rather use this as a year, a bit like going after a master's, a bit like it, which is that you want to take some time and think about a certain area and move ahead with your life and your career.
Exactly. I always jokingly say, don't go to the beach and drink margaritas all day long. You want to make sure that you're doing something within that gap year that looks good, because if you reapply, if you took in that application, we're going to view that. What did that person do to make themselves a little bit better, and you want to have something substantial, and so whether it be giving back to community, doing something to help your metro, you want to demonstrate that you've done something during that gap time.
So we all the committees are different, but on our committee, we kind of look for sort of a general number of shadowing hours, something in the range of 50 plus or minus. And so in the virtual shadowing program, we've tried to get upwards. We're now at close to 100 hours of online shadowing that we've got. And so a question I would have for you, how is your committee going to view the virtual shadowing hours from this website activity?
Well, we take a little bit different approach. We don't look, we take a more comprehensive approach. So what we would like to see at least 100 hours of something, per year, meaning from the shadowing to the community service to the research.
You said per year. Did you mean to say that?
Yeah, per year. Yeah, for academic year. And the reason we use that 100-hour standard is because we have some early assurance programs, students who get accepted directly from high school or get accepted, as a sophomore in college. And that's the standard that we have for them. We have that standard. You have to have 100 hours logged in of something. And for that particular group, it's, 80 hours of community service, of research, of, you name it, participation, even intramural sports. And then the 20 hours is what per year, it's like what we look at for the shadowing part. Now, the regular applicant doesn't have to have that, ratio, but what we try to look at least 100 hours of everything, right, of something.
And so given the pandemic and the inability to do physical shadowing for many people, if not most, you will take virtual shadowing opportunities into consideration for out of that 100 per year?
Yes, sir. Very much so. Because we understand, I think from the group in this audience, I want to reassure everyone, I think, and just having conversations from other schools in Texas in particularly, we understand how difficult this pandemic has been. And so we understand that the application is going to look a little bit different in the context of that whole healthcare activity section. So all I would recommend is try to do something, whether it be this virtual shadowing, maybe forming some form of mentorship with physicians, even if it's on a telephone or virtually, doing something to be able to put down on that application that, you'd be taking some steps to really get a good understanding of the profession that you want to seek later on in life.
Thank you, Felix. Rachel, we've taken a lot of Dr. Morales' time, but why don't we give him, Felix, are you good for maybe 2 or 3 more questions?
I'm good. I'm sure. I'm good.
All right, Rachel, take it away.
We have a lot of questions, if you don't mind answering some of them.
No, go ahead.
One of the questions from students has been, As a reapplicant, what are medical school admission committees looking to see changed on your application? Should you rewrite your personal statement? What are your thoughts on that?
So I'll take that first, the last question first. So when it comes to your personal statement, I would highly, highly recommend now that you rewrite it. Now, do you have to reinvent the wheel? The answer is no. So if you have really good themes on that personal statement, you use those themes. Just don't copy and paste forward, because there are committees, and I can't name them, that will go back, review that. And if you copied and paste forward, it does look really poorly for some schools. Now, I would say to try, like I mentioned beforehand, if you're going to be a reapplicant, hopefully you can objectively look back at your application, right, and say, what if you didn't get an interview? What could I have done different? Was it, just essay wasn't great? When I go through an advising session, I'm going to give you guys just a big broad brush. When I go through that holistic review that I went through with you guys, I try to cover every component, and I go through the application. I say, healthcare good, surgery good, essay is not that great, doesn't, and I try to be as objective as possible. And I because it's really easy to zone in on metrics, right? And I save that at the very end. And I say, well, maybe you need to consider if you're in that 497, 498, 489 range for MCAT, retake it. If you're in that 500, 501, 502 range, retake the MCAT. And if there's a metric issue where we feel like, we were not confident of your ability to handle that the rigorous coursework in medical school, I'll be honest and say you might need to take a little bit more upper division biology course or something like that to enhance your application. So you want to make sure you're doing those things to make sure that you're demonstrating that in your application. There's going to be a portion of the application that talks about what have you done different. You want to make sure you populate that. Now, if you got in and you feel like you had a great application, or if you got an interview and you start taking a step back, why didn't get in? But you got interviewed, then you start, hopefully the light bulb's turning on. Maybe it was the interview that cost me my ability to get into medical school. So at that point, you got to be honest with you. Did I come off as being too strong of a personality? Did I become not interested? Because we get people come as an interview to our school, but then they're like, they're just like taking space for someone who wanted to really be there, right? And oftentimes you want to be engaged in your interview. You want to make sure you're talking to that interview. You want to make sure you're able to communicate really well why you want to be part of that school. Okay.
So going off of talking about interviews, do you have any advice for our students, especially our students that are nervous about interviews?
I would say is one, make sure you know every detail of your application, because anything on that application is open game, right? So anything that's on that application could be asked as a form of a question. So make sure don't fib about even your leisure activities, right? I caught someone like 5 years ago who was fibbing about even the leisure activities, right? So you want to make sure that you know your application backwards and forwards. That personal essay oftentimes becomes a great topic of conversation when it comes to questions. So you want to make sure you have a well-written one. And that's actually our personal strategy, making sure you're conveying a good message and being prepared to answer those questions. A simple question we ask all the time is, why medicine, why a doctor, those types of things. Dr. Fowler and I were talking beforehand and about, having a backup plan, right? And I always say, some people will ask, what happens if you don't get in? What are you going to be doing? Be prepared to answer that question. But I would always make the recommendation, so maybe I'm going to do this, this, and this. But ultimately, I want to become a physician, Dr. Morales. I want to keep on trying until I get in. And it would be a good way. That just shows some sense of perseverance for sure.
So Felix, we're pretty settled on the fact that we're going to be doing virtual interviews this year again. What about your institution?
Same thing. The advantage for us is obviously we're able to get more students involved more applicants and more faculty involved in interviews. Our disadvantage as a school, as an institution, is the fact that we want students to come to our campus because then we can sell them on our culture of our institution. We have a very collegial environment. We have a very friendly environment. We are a family at Texas Tech, and you get that sense when you come to medical school here, and sometimes that's a little hard to convey on a virtual platform. And we also will love to sell them on our facilities. We have, I think, second to none gross anatomy lab. I mean, 20,000 square feet gross anatomy. Our facilities are second to none, you know, and and for us, that's important to get them on campus. We because the perception I think that most people have about Lubbock, Texas, that it's just this, you know, run of the mill, podunk, you know, farm town, right? And there are farms and cotton fields around us, obviously, but it is a city, you know, we have city vibes, you know, and we want people to get a good sense of that. And I think that's a disadvantage for us. But for the next year, we are going to do virtual.
So Felix, to follow that up, I've been thinking quite a bit, and I know you've read a bunch of the interviews with students about the virtual environment. And you know, I'm going to look you straight in the eye right now on the screen, and you'll notice that I'm looking downward like this because the green light is up here. Do you think that there's certain techniques of virtual interviewing where, for example, you get accustomed, like I'm doing now, to staring at the green light? So now it actually looks like I'm looking you in the eye.
Yeah.
What about the background? What should you wear in a virtual interview, and so on?
Take it. Well, first about what you wear. You want to prepare suit, tie, you know, nice, you know, business suit for ladies. The other thing too, you want to make sure the Wi-Fi is good. You also want to make sure if you're going to use headphones that they're not going to be these monster, you know, Beats type of style headphone. The backgrounds, also the lighting's important too. I think of that as well. But another trick that I've done too is like, I'm staring at myself. I'm talking to myself right now because I have a hard time looking at other people in the course of a virtual, you know, kind of Zoom type of meeting. So when I speak, I directly speaking to myself. That keeps my eyes focused on my screen. What not to do is, you know, don't, you know, do this, or, you know, you're looking around, you're talking that way. Because we had several interviews that just, they're staring out the window and they're trying to be philosophical about their answer. And it's like, no, it's not working. It just seems like you're disinterested. And the other thing too is you want to make sure, and this is a tough one because if you have a family, that's always hard, but you want to make sure you're in a quiet room because oftentimes you can hear a lot of background noise and, you know, family members talking, and, you know, so you want to make sure you're staying focused on that and having a nice quiet place for yourself.
So maybe you shouldn't have your cat crawl across the keyboard during
it has
the interview.
happened, and it has happened. Yeah, for sure. Yeah, the cats they're notorious for trying to be the center of attention. Yeah, and I've seen it for sure.
We did have a number of interviewers this year. I mean, we reviewed almost 800 interviews at 2 interviewers each. And it was interesting how a number of the interviewers said we had connection problems and the student was able to help me fix it, which means that the techno geek knowledge of folks that are younger sometimes actually played positively because they knew how to fix problems with the software.
You know, and we have just my office staff in our office, and we got 2 tech gurus that are just top notch, and they're able to. Now we have had students who, you know, and not every student comes from, you know, sometimes finances and, you know, play a big role in Wi-Fi, right? And so there were instances that we were, you know, if the Wi-Fi connection wasn't good, they were having to use a hotspot off their cell phone, you know, those types of things. We're understanding of that. And so if an interview got cut off or froze, we did our very best to recalibrate that interview and give them another chance.
Rachel, take it away.
We had an interesting question. Out of all the qualifiers for acceptance into medical school, such as GPA, extracurricular, so on and so forth, what do you feel is most important?
It's easy to say someone's metrics, right? But for us, what we use metrics is, hey, can they handle the rigor of medical schools? An MCAT score is not going to tell us much about how good of a physician they're going to be later on in life, but can they handle that first year? Can they move on to the second year? Those types of things. For me personally, it's something that we try to train our evaluators of applications is, you know, how passionate are they about pursuing this career path, right? How dedicated are they going to be? There's a big buzzword in admissions, grit. You know, how gritty are they going to be? And do they have that sense of grit? We're literally doing research on that through our applications. And so passion, perseverance, grit are the big three things that we try to get out of the application. And then for us personally is why us? Why Texas Tech? How can we help facilitate that dream, right? And so we're trying to figure those things out through the course of the application. So those things mean a whole lot to us. Now I know they're very broad and not necessarily specific to that person's question, but those are the things we try to get out of that for sure.
Gotcha. And then, so you brought up why Texas Tech. How would you recommend students narrow down their medical school search? There are so many great programs to apply to.
I would say a couple of things. One is, you know, and there again, I have such wonderful relationships. I mean, I consider, you know, a few people who were in my position in other medical schools as mentors, because when I got into this role, you know, Dr. Peck retired, and, you know, and for health reasons, and I didn't want to necessarily bother her with questions. And so I reached out to other people. So every medical school you go to in Texas, you're going to get a really good quality education. I never like to say anything disparaging about any other school, but as you start narrowing down your choices, right, you know, you start thinking about, okay, what school can help, one, provide the best comprehensive education for me. You know, what school can help out in regards to, you know, putting me in a position where I'm going to have a good, solid, you know, medical science foundation. I want to get a good clinical exposure. Those things are going to be very important in regards to how you see that, right? You know, some schools might be a little more research intensive. You know, if that's your interest, then do that. If it's not, and you just strictly are thinking about just your strict medical education, think of those things. You know, that's how I would go about narrowing. You know, and also you have to ask yourself the question during the course of an interview, or when you come back and you start reevaluating, do I see myself fitting in well with the group of students that are currently there? Because a big majority of your interactions are going to be with those groups of students, right? And you feel like, do I fit well with that group? You know, am I going to feel like a part of a family? You know, and those are the things I would recommend for sure.
Gotcha. We have a lot of amazing non-traditional students in our program and also here tonight. What are non-traditional students looked at differently than traditional students?
The answer to your question is yes, but not in a negative way. Well, we look at, and we have a big portion of our students who apply and also who get in are non-traditional, right? And the reason we like, there's seasoned people, right? You know, and we actually had a young lady the other day speak to a group of pre-med students here at Texas Tech, and she was a DA, and she took a path of, you know, not getting into medical school for 8 years. You know, she taught overseas. You know, and now she's in her 30s, and as she put it, you know, when she looked back at her, you know, 21, 22-year-old self, she didn't think that person could handle the rigor of medical school the way that she can now, right? And so, you know, oftentimes our non-traditional grads are the ones who are going to be very hardworking. They're going to be, you know, because they've dealt with, you know, kids and managing time and having to have a professional career. And so we don't necessarily look at it in a negative way. If anything, it's more positive, you know, and for us too, when we start looking at things holistically like that weighted scale, if we notice someone couldn't shadow as much or couldn't do research, and then we start, why? Oh, well, crap, they had a 40-hour work week, right? They had 2 kids. They were a little league baseball coach. You know, they did these types of things to be able to help their family out. And on top of everything else, they were still pretty successful at academics, right? And so, so that's how we go about looking at those non-traditional grads. We don't ever look at it in a negative way.
Gotcha. Some students wanted to ask if it was okay to talk about in like personal statements or secondaries, death, mortality, or, you know, mental issues such as anxiety or depression, or is that kind of a no thing to mention?
No, it's not. And, you know, and y'all's generation of young people, I'm always very impressed in how open you guys are about mental health. And I grew up I'm a Gen Xer, and it seems like it's always been very taboo in regards to mental health issues. And I so deeply appreciate how open people are about overcoming those things. I would always say is just try to make sure you have a positive spin on it. In other words, if you had some anxiety issues, if you had some issues with mental health, that you put a positive spin and say, this would happen, this event in my life led me to this path, but then something inspired me, or something inside of me make sure you're always trying to create a positive spin on that part of it. The death part, if he had to, you know, a big portion of my personal statement was, you know, talking about my dad and his health issues, right? And so, did my dad die? No, but he almost died, you know, when I was 13 years old. And it kind of helped me kind of solidify why I was motivated to why I want to become a physician. So don't be afraid to do that, but I always say try to make sure you're spinning it in an inspirational, positive way.
Gotcha. A couple of students, you know, with online learning, there's pass fail. Does having a pass fail for a prerequisite make a difference in the application?
Well, there's no way, you know, I think our policy at the moment, I think we're probably gonna have to republish or restate it. You know, I think we're still gonna be lenient toward that pass fail situation when it comes to the prerequisite coursework. Yeah, and part of that is because you guys had no way of knowing that this pandemic was going to happen, right? But my suggestion on that would be, if you know, there's no way we can police it as an office of admissions, right? But if you had the ability, if given the option between pass fail and categorical grade, letter grade, choose a categorical grade, you know, because, you know, if we start noticing students from same schools and one has pass fail, the one has, you know, we're going to start questioning that part of it. So I would really recommend the categorical grade path if you can. If you have a school that doesn't allow that, and yeah, we're going to be lenient over the next couple of years for sure on the pass fail situation.
Gotcha. And then is it bad to retake a prerequisite or have a low grade in one of those?
You got to keep in mind when you apply to medical school, every single grade, there's no grade replacement on your transcript. So I would say, is it bad? No. Now, if you had obviously a D or an F, you definitely got to retake that course and shoot for an A. If you had a C and you felt you were confident to maybe make a higher grade, then I say go for it. But you got to keep in mind that D or F or that C are still going to be calculated into your GPA. But I would highly recommend, if you make a C or lower, retake it. You know, try to aim for an A if you can. Okay.
Gotcha. And I think you've inspired several students tonight to go to Texas Tech in the future, but some might be out of state. Or out of state applicants at a disadvantage when applying to Texas medical schools?
Well, we're limited to how many we can accept. I think every public school can only accept 10% of their class from an out-of-state pool. And so that's the reason those metrics are skewed much higher. And so there is a slight disadvantage to that, just because, you know, we can't have more than 18 people from our medical school class be from an out-of-state pool. You know, part of it's a funding issue, part of it is just a missions issue. And so there is a slight disadvantage because you're going to be competing against some pretty competitive folks, as you saw, you know. But we still love our out-of-state applicants. You know, I've mentored plenty through my time as a faculty at Texas Tech. And so, but yeah, it's going to be a little bit tougher for sure.
And then I think our students are also a little concerned. Is this number the same for other states and their medical schools?
That's a great question. I don't know. I don't know. I have a young junior in high school right now who's looking at wanting to apply to schools out of state, and he mentioned a few schools. Like the other day, he was talking about UCLA. I'm like, I don't know if they have the 90-10 rule in California. You know, so I don't know. It's a good question. I wish I had a better answer for that, but maybe if I find that answer out, I can maybe email you or Miriam on that. Okay.
Yeah, absolutely. Let's see. There's so many questions flying in. Do you perceive that virtual interviews will continue past COVID?
I think there might be some form of a hybrid. I think for us, and particularly, you know, going back to how I would love to have students on campus so we can show them, they can feel our warmth, right? They can feel our our family, the environment that we create. So I think this next year, this cycle is for sure going to be all virtual. I think in the future, we'll probably have some form of a hybrid format, because we're able to accommodate more students, and in particular for our school, we're able to accommodate those faculty members who are from our campus. And so we might have a situation where a student shows up on campus, but they're interviewed, by someone in Odessa, Texas, right? And we still do it a virtual platform. So there might be some form of a hybrid format for sure.
Gotcha.
Hey, Felix, you mentioned several types of interviews, including a blind interview in which all you really have is the picture of the student and nothing about their transcripts. Why would you have an interview where the interviewer knows nothing about the person academically?
Well, I'll explain it from our perspective. Like, we have the semi-blinded part of it, right? Because they have the application statement, everything else. We don't want our interviewers to be biased in regards to the numbers. So for us, it's more important to us for that student to be an institutional fit, for that student to be who wants to be a part of our tech family, more importantly, because we've had instances where metrics do appear somewhere on an application that we can't go and strike. And that's all what the interview focused in on. And so we want to make sure that our interviewers are not going to be biased by numbers. We want to make sure that person who has a 502 has just as good of a chance as that person has a 525. And
so you're saying that in the interview, then they're getting to know the person to see who they are.
Exactly. And the blinded part of it, I like that one school, when I asked for them, it's about getting to know that person, but also just checking on their communication ability, right? Because as you know, as a physician, I mean, a big part of your job is communicating back to your peers, your nurses, your patients, and so part of it is just the ability to communicate. It's very important as well.
Absolutely. Well, we've taken so much time out of your night, but thank you so much for giving us an insight into Texas Medical School admissions and sharing a little bit about your passion about family medicine. You have just inspired so many students tonight. And let me talk about the assessment really fast, and I'll give it to Dr. Fowler for some closing thoughts. So let me share my screen. And then 1%. Sorry, it's slow. Do y'all see it okay? Right.
Yes.
Cool. So this is our information for assessment 51. You can take a photo of it. We'll also be posting it on our Instagram. We'll send it in our emails, and we'll also post it on our website. You have until next week, 5/18 at 6:59 p.m. Central Standard Time to complete and pass this assessment. And yeah, good luck on that. Dr. Fowler, do you have any closing thoughts?
Felix Morales, what a wonderful talk. Thank you so much for coming and sharing your warmth and your amazing skill, your clinical skills, but now your management skills about trying to make doctors for the state of Texas and beyond. Let's have everybody, all nearly 400 of you, put a thank you, Dr. Morales, into chat so he can see that. Felix, thank you again. Folks, we're going to be here if you keep coming back. We're planning to keep rolling in July, including doing one of the meetings where we will actually practice interviewing. So looking forward to being with you. And on behalf of the entire virtual shadowing team, Dr. Morales, thank you so much. We want to thank you all for coming, and we wish you a wonderful evening.